Hello, it's a real pleasure to be here, albeit virtually, and thank you very much for the opportunity. And today I will be discussing advances in the surgery for Parkinson's disease and dystonia, and we'll be emphasizing the activation of cerebral circuits with DBS as assessed with fMRI. So it is indeed safe to do fMRI in patients with DBS, and we've done this now in over 100 patients, and we've done some research on testing the specific fMRI sequences, and this can be done with phantoms, and the main risks are producing heating along the wires in the brain, and of course one can choose sequences and that allow imaging with fMRI that are safe. Now, what we are specifically looking for is whether one can produce a specific signature of brain activation with the DBS. Can we measure this with fMRI? And specifically, does the topography and the nature of the brain activation, does it depend on which contacts and which stimulation parameters we use? And could we use this information to predict the optimal stimulation that will produce a distinct pattern? So if there is a pattern that correlates with good outcome, can we identify that pattern, and can we stimulate to produce that pattern? And of course, identifying this pattern would be very, very useful. So to do these studies, we've chosen patients with Parkinson's disease and who've had bilateral ST and DBS. And we first looked at 20 patients that were already operated and in whom the expert neurologist, in our case, Dr. Lozano, had identified which was the best contact. And we're asking, what is the pattern of activation when we apply stimulation at the best stimulation parameters, at the best contact versus the other non-optimal contacts? So this is done by placing the patients in the fMRI unit and then going contact by contact and looking at what pattern of brain activation is achieved when we move from one contact to the other. So we start off with the first optimal contact seen here in green, for example, at the bottom, and we do a block design of 30 seconds on and off, and we acquire fMRI signals during this block design. This takes a total of 6 minutes. We then move to the next contact, which is non-optimal, and then to another one and to another one. So altogether, we do 4 fMRI sequences, each at one of the contacts, and we look at what patterns are generated by the stimulation of each of these contacts. This has just recently been approved for acceptance in Nature Communications by a very talented postdoc in the lab, Alex Boutet. So this is what we find, and I'll draw your attention to this panel over here, which is labeled the optimal contact. And what we find is a very striking deactivation of the primary motor cortex, seen here in blue, at the optimal settings. We also see some activation at the site of stimulation seen here in red. If one moves from this optimal contact to now the adjacent contact, we'll see that the same pattern exists, but the magnitude of the change of the signal is decreased. And if one moves to a distant contact 6 millimeters away, we see that the pattern is even less prominent. Similarly, if one goes in the other direction, you see that if you go to the non-optimal contact seen here at the bottom, you see a very complete different pattern of activation. So it is very clear that the optimal contact gives you a very specific signal. And as you move away from the optimal contact, you get either a degradation in the signal or a completely different type of signal as you move to a suboptimal contact. So this is the case in one patient. We then pooled the results in 20 patients, and exactly the same pattern emerges. So you see here on the left side, you see the pattern of deactivation of the primary motor cortex with optimal stimulation settings and stimulation at the level of the DBS electrode seen here in red. And then as you move away towards non-optimal contact, you get much less deactivation of the primary motor cortex, and you start to see spillover into activation of non-motor area. So we think that this then is a signature of the optimal contact, which is separate and distinct from the pattern that you achieve when you stimulate at the non-optimal contact. Indeed, we know that these are the optimal contacts because we get the best clinical response seen here on the left side, where when we single out the optimal contact, we get the best improvement in the UPDRS seen here on the graph on the left. And also we get the largest signal in the M1 motor cortex region when we're at the optimal contact. So the largest deactivation in the bold signal is seen when we're at the optimal contact. And as we move to adjacent contacts that are further away from the optimal contact, then this signal disappears. So the hypothesis is, if we know which contact gives us the best clinical result, and we know the pattern that is generated by stimulating out this contact, could we use this information to help guide the programming of DBS electrodes? Keep in mind that the programming of DB electrodes is quite complex. It takes, in our center, we wait 1 to 2 months after surgery for the first programming session, and then it takes an average of 3 or 4 programming sessions until an optimized DBS setting is achieved. So this involves quite a bit of time and is quite tedious for the patients and for the neurologist. Furthermore, with the introduction of now multiple segmented electrodes, the complexity of the programming becomes even more challenging because there are many more combinations. So the idea then is, can we use fMRI to program the patients? And here the endpoint will be to achieve a fMRI signature to then, instead of a clinical response, to guide the programming. And we've done this by choosing the 20 patients that I've told you about already as the source data. And then we prospectively studied 19 de novo patients who had not been programmed to see if one could use the fMRI to choose the optimal stimulation contact and parameters. So these are the results. And here in the prospective cohort, we see that indeed one is able to find stimulation contacts that produce a signature of deactivation in M1 and of deactivation in the contralateral cerebellum. So this is the signature that we're looking for. And if we move to non-optimal contacts, as you see here above, 3 millimeters above or 6 millimeters above, you'll see that you do not see the same pattern of M1 and cerebellar deactivation. And so indeed, it is possible to, in de novo patients, reproduce this optimal fMRI pattern, signature pattern. We also wanted to add the issue of voltage, and we know that patients are very dependent on voltage for the optimal response. And indeed, if one looks at the bottom, changing the voltage has a striking effect on the fMRI pattern. If one chooses the optimal voltage, usually in the order of 3.5 volts, then you see deactivation of the M1. But then as you decrease the voltage to something lesser, you see less of a signal. And if you increase the voltage beyond the optimal, then you start seeing spillover into non-motor area. So it looks like one can choose the optimal contact, giving a signature on the fMRI, and also the optimal voltage, giving the optimal signature on the fMRI. So what this means then is that one can then establish a machine learning algorithm where the patients have surgery, they have an fMRI to choose which is the optimal contact. We use a classifier and machine learning to identify which is the optimal contact. We can then apply different voltages at the optimal contact and choose the best fMRI signal from these various voltages to choose the voltage. We can use a classifier, and then we can come up with a combined optimal contact and optimal voltage for these patients. And indeed, this is what we've done. And what we found, and I'll just draw your attention to this part of the graph here on the right with the stimulation naive data set, is if we just use the optimal contact, we can predict the best stimulation parameters in about 60% of cases. And if we, once we know the optimal contact, if we choose the, we can use the voltage data to also help predict in about 60% of cases what the best voltage is. And if we combine the best contact and the best voltage, then we can predict the best parameters in approximately 80% of cases. So what this means then is that one can identify the optimal contacts using fMRI, and these optimal contacts then generate a specific engagement of the motor circuit and tell you that you are on the right track, that you have achieved what you wanted to do by engaging the motor circuit that is responsible for the clinical benefit. It is also quite clear that the pattern of brain responses of the optimal contacts and optimal voltage is quite distinct and different from the non-optimal contact, and this is quite important. What this means is that these findings could be used for MRI-based DBS programming in PD, and importantly, in other disorders where there may be a long delay between stimulation and benefit. And indeed, this is a potential step towards a self-programming system. So with this in mind, we now want to also look at dystonia, and dystonia is particularly interesting because there's a very long delay between applying the stimulation and having a clinical benefit. So here, having an fMRI signature would be particularly important if it's predictive of long-term benefit. So as you know, we place the electrodes in a different target, usually in the GPI in most cases of dystonia. And in dystonia in particular, we are plagued by this delayed and progressive benefit with pallidotomy and DBS on dystonic symptoms. So there's a long latency, often weeks or even months, between the intervention and the clinical benefit. And this lack of immediate clinical benefit really complicates the programming, because it's possible that you might be at the optimal setting, but because you haven't waited enough, you actually move to a new setting that is suboptimal. Because you didn't wait long enough to produce the clinical benefit. So here, getting a biomarker of successful programming is particularly important. So we've recently submitted a paper on fMRI in dystonia, and Aaron Lowe is a talented MD PhD student who has done this in Toronto in our lab. We have studied 11 patients with various forms of dystonia, seen here: cervical dystonia, truncal dystonia, generalized dystonia, and DYT1. These patients were ill for many years, and they were all seen as responders, anywhere between about 40 and 100% improvement in their dystonia scores. We implanted these patients in the GPI bilaterally, and then we studied fMRI, the fMRI pattern at the known optimal stimulation settings and at adjacent non-optimal contacts to see if there was a difference. And indeed, there's a very striking difference. And so if you see here on the pattern in the middle, these are now the 11 patients that are pooled, you'll see that compared to optimal stimulation versus off, there's a very striking deactivation in the sensory motor regions of the cortex in optimally stimulated patients. If one goes to non-optimal contacts, then you see less of this pattern. And if you compare non-optimal versus off, you see a very different pattern as well. And so it is very clear that the optimal pattern of fMRI activations is seen with optimal stimulation, and this has a strong clinical correlate, because the greater the magnitude of these fMRI changes at these pre-specified sites, the greater the clinical improvement. You can see here that the actual improvement very closely correlates with the predicted improvement, and one can use the magnitude of these specific changes at these specific sites to predict the clinical response. So not only have we identified these areas that change and that whose changes appear to be responsible for the clinical response, but we've also shown that there is a change in the brain connectivity when one applies DBS to these targets. And what we've seen is that there is an enhancement in the connectivity of the brain in several areas, and specifically between the basal ganglia and the premotor cortex, between the basal ganglia and the central areas, the posterior central gyres, and the medial frontal gyres. So we see that not only does DBS change the activity of brain areas, but DBS also enhances the connectivity of the basal ganglia with motor cortical areas in the brain. So what we've seen in the dystonia is that stimulation at optimal contacts produces a specific fMRI signature. And if this occurs in de novo patients, these patients that we've studied are already established, already identified as optimal benefits to the stimulation parameters. And if it occurs in de novo patients, then the endpoint of program now could become generating this fMRI signal instead of relying on a clinical response. And this means that we could then start programming the patients based on this biomarker, which is short latency, which we can generate within an hour. instead of having to wait for the long latency clinical response to guide the DBS programming. And this really could be the basis for a biomarker-based programming in patients with dystonia instead of the trial and error over weeks and months that is currently in place. So in conclusion then, what we've seen is that indeed it is possible to map out which areas of the brain are activated and are influenced by DBS. These patterns are very specific and vary as a function of which contact and which stimulation parameters are used. I think that this provides not only insight into what areas of the brain are important and necessary for the DBS activity to take hold and to produce a clinical effect, but in fact, it confirms the circuit engagement, and it also tells us something about the mechanism of action of DBS, what areas of the brain are affected and how those areas have to change in order to produce a clinical benefit. What this means is that instead of relying on a clinical response, it is possible in the future that programming could be guided based on a biomarker, in this case, an fMRI biomarker. And this is particularly exciting because it means that one could program the patients quickly, perhaps in one session, or instead of having to trial and error to try something and wait for a clinical response. In the future, it's also interesting to note that perhaps one could envisage an automated or self-programming system where you use DBS and an fMRI, and in a feedback and in an iterative way, get a self-programming system, in which case this might save a lot of time for the patients and for the neurologist, if indeed this proves to be safe and effective. So with this in mind, I want to thank you for your attention and for the honor of being able to present with you. And I want to thank my colleagues without whom this work would not be possible, and specifically General Electric, that's helped us with the machine learning algorithms, and all the fellows that work with us. Thank you very much for your attention.